Our first speaker is Professor Jonathan Morris. So Jonathan leads a perinatal research group extending from basic science through to population health. He's currently the director of the Cochrane Institute for Medical Research, and he's president of the Perinatal Society of Australia and New Zealand. His major research interests are in the prediction, prevention and management of pregnancy complications. And he was the lead investigator of the PPROMT trial, which was the inaugural winner of ACTA Trial of the Year this year. So thanks very much, Jonathan.
So thanks, Katie, and thank you for ACTA for inviting me to talk. Conflicts. So I'm a member of Impact, which I thought we were sponsoring the entire conference, but there we go. Research implementation. So I guess I'm at this stage. I've completed a trial, and that was a 10-year effort, but also trying to think, has it made a difference? And just going to talk a little bit about the reflections of this study. So the clinical issue that we confronted in our study was the optimal time of birth if a woman presents late in pregnancy with ruptured membranes. Basically, the question was, when is the optimal time of birth? Do we plan early birth and expose the baby to the risks of prematurity, or do we wait and potentially expose the baby to risks of ascending infection and potential death? So the PPROMT trial, very simply, was a study to compare two forms of accepted management in clinical practice. At the time, and this was about 10 years ago, guidelines from esteemed bodies, so here from the Royal College, suggested that early birth was appropriate management. The American College similarly suggested that if a woman had ruptured membranes at 34 weeks, early birth was associated with less risk. And this was predicated on a systematic review of evidence that really showed there was no support for that. And I guess something that we do need, and what I've learned, is that increasingly guidelines are being put out which advocate practice change in a complete lack of evidence. And I think we've really got to call these out. In my own practice, we're using thromboprophylaxis after caesarean section, no evidence whatsoever. But bodies, self-appointed quangos, put themselves out and suggest practice change. And essentially, we need to think about how do we allocate people to randomized care and not these random ideas. At the time when we started the study, it was true that our clinicians were in equipoise over the optimal timing of birth. So we did a study. It was across the world, 63 centers in 11 countries. And I just put this slide up because when the study came on board as a priority study for the Clinical Research Network in the UK, it really meant we got over the line. And I think the NIHR, I was in Oxford at the time it was being introduced, it really has very successfully seen clinical research become part of clinical care. The biggest impediment, I think, to embedding research into clinical care is the word research. In my own institution, it's seen as something done by people that aren't involved in health. And it's a real paradox that I think research is an impediment to embedding research in health, the very word. And I think the Clinical Research Network, which identifies those studies that clinicians and consumers want an answer to, and they support their completion, was fabulous. So essentially, this was a study that randomized just under 2,000 women to early planned birth or expectant management. The primary outcome was neonatal sepsis, and we hypothesized there would be a reduction in neonatal sepsis, and in actual fact, the study showed there was no difference. What the study did show, however, was that in terms of our secondary outcomes, babies had more respiratory distress, and there was a greater need for ventilatory support. This translated into an increased likelihood the baby would spend more time in intensive care and in hospital. And for the mother, it meant that she would early planned birth, which was being advocated by guidelines at the time. It meant for the mother there was a greater likelihood of caesarean section. She did have a shorter stay in hospital. So to summarize, this study, which was NHMRC funded and took about 10 years, showed there was no difference in sepsis, But in terms of secondary outcomes, there was greater risk for the baby. So this was published. There was an accompanying editorial in The Lancet, which suggested that it pays to wait. We should change practice. And currently we've updated the Cochrane Systematic Review, and NICE are reviewing these findings to try and address and bring out new guidelines. So the updated Cochrane Review now shows that for the baby now, early planned birth is associated with risks of ventilation and respiratory distress. Now, the Americans were interesting because within 4 hours of The Lancet being published, this came up on the UpToDate website. You know, you Australians, what do you know? This can't be extrapolated to women in the United States. You know, they found all these problems and said, we continue to recommend delivery rather than expectant management for late preterm prom. So I'm supposed to be talking about how to translate evidence. Obviously, there's a difficulty. And I guess this, to me, is the difficulty. This is brilliant. Sue, what do you see there? So this is Colgate advertising their dental floss. What do you see? You know, this poor guy, look at him. It's quite interesting because we get so consumed with our view of the world, we sort of say, well, I wonder whose this arm is. You know, oh, she's got 6 fingers, and where's his ear gone? And to me, this is the problem with our healthcare system. We are so consumed with the minutiae, we lose the big picture. And we've heard a little bit about that this morning. And I think this is where data does help us. I just want to go through with you. So the Americans want early planned birth. The study that the clinical problem our study confronted was the same as many others. We like doing things in health. And if we look at all the births in New South Wales since the time I've been a specialist, in 1994, pregnancies used to last 40 weeks. That's what I was taught. If we look at all the birth distributions for singleton births, so about 100,000 births a year, since that time, look at what's happened. This isn't the result of randomized trials. This is the result of random clinician good idea. Now this, at a population level, is enormous. As I often say, if Donald Trump could have, if Hillary could have changed her opinion liking from this to this, she would have swamped home. At a population level, this is an enormous change. This isn't evidence-based. This is because clinicians and mothers and families are saying it's more convenient or it's safer to end the pregnancy rather than to continue. The Americans continue to advocate early planned birth because they believe that in the long term, it's safer. It reduces the exposure to infection. So the power of data is that what we're now doing is saying, well, we can't follow up the women in the PPROMT study and their babies. It's too small. But what we can do from routine data is to begin to follow up babies that were born in similar circumstance and say, how do they do at school? And these are the data. So basically, when your child starts school in Australia, every 3 years, the kindergarten teacher does a kindergarten assessment test on 5 domains that range from numeracy, reading, social skills. And what we can see is that every week down to 39 weeks, there is a population level difference with a baby being developmentally at risk. The baby's brain at 35 weeks weighs about 2/3 of what it will at 40 weeks. Lex Doyle, who's here today, his group have done remarkable imaging studies that show if a baby's born at 35, 36 weeks and you image their brain at 40 weeks, it looks different to a baby born at 40 weeks. So I think when we restrict these analyses to the babies that were in our study, we find the same findings. There is no doubt that what guidelines have advocated and what the Americans still continue to advocate potentially is associated with harm. And I think this is really important because it shows that sometimes we can use data to begin to corroborate longer-term effects of studies, and we can use data to begin to measure whether our clinical trial findings are being implemented. So what did I learn from the PPROMT study? I think we really need to stop these guidelines being produced that advocate practice change in the absence of evidence. So we should call them out for what they are. I think clinical research networks embedded into health are essential to complete investigator-led studies at scale. Clinical practice change is challenging because still, as we've heard this morning, much remains based on assumption. And I think data linkage will assist in measuring practice change and other long-term outcomes. So I just want to thank all those involved in the study, the various funding agencies, for ACTA, for initiating the Trial of the Year Award, obviously all my collaborators, both on the PPROMT team, but the wider Impact Network, which is a sheer pleasure to be part of, and thank you.
So, questions for Jonathan? I might, oh, I was going to say. Professor Flanady. Associate Professor yesterday, Professor Flanady today. Congratulations.
Jonathan, you sort of skirted around the reasons, the 10-year time frame to do the trial. So could you share with us what those, why it took so long?
That was me, was it? So I think it took a long time for a number of reasons. One is that the women to whom this study was offered present around the clock, often out of hours, and that's very hard to service that if we rely on sort of individual research staff who often just work office hours. I think it was also that not all women presenting were offered the study. I think because often clinicians had very clear perceptions about what they thought was best management. I won't mention ethics and governance, but ethics and governance delays. And again, I think it is the perfect example where practice is already, these divergent practices were in place. We should have been able to do this more efficiently through potentially an opt-out mechanism. Yeah.
So Jonathan, I had a question for you a little bit along those lines. So I was involved in the PPROMT trial, and our unit did appallingly badly at recruiting to the study, which I'm very embarrassed about. But I think you suggested there was equipoise 50-50. I don't think there was equipoise. I think 50% you thought one answer and 50% the other. So it was hard to get clinicians on board. But the thing that I found really hard is once you explained it to women, they thought you were giving them a choice, because we were saying we didn't know what the answer was. And they said, well, I won't be in the trial. I'd like to choose that one or that one. And I wonder if we need to be looking differently in how we can recruit to these sort of trials where it's almost comparative effectiveness, really, and the opt-out rather than opt-in.
I think it's really interesting because there is no doubt that when we're discussing studies with patients or possible people who may join, we raise anxiety. We go into far more detail. On the one hand, there's this risk. On the other hand, there's that benefit. When in clinical practice, we say, sign here. And it's really, something that really came home to me is that through doing research, we raise anxieties because we cover things that we would never normally do in practice.
Yeah, hi, it's Paul Miles here. An argument's often put that if you embed the research in clinical practice, the translation of the results happens much more quickly and completely. I guess the question is, if you had your time over again, would you have included US centres in the trial, and would that have perhaps led to a different interpretation of the results?
We did approach North America. They're very difficult to get to come on board. They often like doing their own studies. I think it would have been marvellous to collaborate with them. And I'm sure we have got different results. We would have got results more quickly. I'm confident of that.
Peter McIsaac. Given that you had 10 years to do this, would an alternative approach have been to have done an in-practice research model where you assiduously collected information about what are the confounders, the likely confounders and factors that would impact on outcome, and then collect that data across multiple centres, including the US? Had that idea occurred, or in fact, now that you actually have the outcome, could you actually see whether you could have found this out by doing an in-practice research model, allowing natural variation in care to provide the to provide the effectively the driver for the study rather than the randomisation.
So thanks very much. And it's interesting, we did hear someone this morning suggesting the truth could only be arrived at through randomised trials. I must admit I wouldn't concur with that, and I concur with you that I think through population health data, propensity matching, I do think we can get sufficiently close to how we can essentially evaluate best practice. So I think there are other ways of doing this, and I think it does. We are very fortunate in maternity care that we've got the best registry because, you know, there is a minimum data set on every pregnancy and birth in the country, and we hope to use that in the sort of ways that you suggest, because I think there are ways to evaluate differently.
Okay, thanks very much.